Good evening, class. After discussing hyperthyroid and hypothyroid disorders last week, we now move to the third category of thyroid disorders, which are your thyroid nodules and your thyroid cancer. Again, this is Dr. Ana Angelica Macalalad Josue. Welcome to today's flip class. So for today's flip class, I'll be using a lecture that was developed by Dr. Nicodemus. Dr. Nemencio Nicodemus is a professor of the University of the Philippines College of Medicine, and he did this talk under EXCEMED, which is a resource, a website where there are lots of resources for teaching cardiometabolic disorders, including thyroid disorders. So we'll be using his lecture for today, and I will post the original link to the original talk that he did several years ago on this topic, and I'll post the link in the description of the video. So we'll talk about nodules, thyroid nodules, and thyroid cancer for this flip class. So the objectives of this lecture is for you guys to understand the prevalence of thyroid nodules and thyroid cancer, and then we will be discussing the diagnostic stepwise approach to approaching thyroid nodules. If you're presented with a patient with a thyroid nodule, what will you do? So next, we will discuss briefly the ATA guidelines for differentiated thyroid cancer. And your differentiated thyroid cancer includes your papillary thyroid cancer, which is the most common thyroid cancer, followed by your follicular thyroid cancer. So this talk will not include medullary thyroid cancer and your very aggressive type of thyroid cancer, which is your anaplastic thyroid cancer. So first we start with a case. CD, a 45-year-old gentleman who came in for a lump in his neck. So apparently well until a day prior to consult, he noted a lump in his neck while he was taking a bath. So there's no history of head or neck irrigation, and there's a family history with his sister of goiter, and her sister had had surgery and radioactive iodine ablation for this goiter. And when you physically examined the patient, you noted 2.5 by 3 cm hard nodule on the right thyroid lobe with no palpable cervical lymphadenopathy. So, presented with a case like this, how do you think you should proceed with this case? Okay, so thyroid nodules are fairly common depending on your population. So, for example, in the Philippines, if you try to detect thyroid nodules by palpation, they were able to pick up about 4.4% of the population having the presence of nodules. While in a study in India, they were able to pick up that 12.2% of the population have palpable thyroid nodules. However, in other studies where they used autopsy to detect thyroid nodules, you would see a higher rate of detection. So, it depends really the prevalence of nodular thyroid disease on the population being studied as well as the methods used to detect nodules. So, for example, you use the more sensitive methods such as your, let's say, ultrasound, then the rates of the prevalence of thyroid nodules will be much higher as opposed to palpations and autopsy. So, what is a thyroid nodule? So, in the past, any palpable lump in the thyroid gland will be called a nodule. So, that's the old definition. But now, your thyroid nodule, with the onset of with the ultrasound being a more readily available tool for screening for thyroid disease or for detecting thyroid disease, it's now defined as a distinct lesion that may be differentiated from the surrounding thyroid parenchyma by ultrasound examination or other sensitive imaging. So, such as your, let's say, thyroid scan or even CT scan can pick up also thyroid nodules. So how do we approach a patient with thyroid nodules, such as in the case of CD, of course? The first thing we need to do is to do a basic, thorough history. Okay, so you need to ask the appropriate questions to be able to give you more information of what kind of thyroid nodule it is. From the history, you'll be able to pick up signs whether this is a hyperthyroid or a hypothyroid patient. You'll be able to pick up characteristics of the patient that will give you clues whether this patient is high risk for malignancy. And later, I'll show you which are the risk factors for thyroid malignancy. Next, you do a thorough physical examination with focused on your thyroid gland. So you guys should remember how to appropriately examine the thyroid gland. And their physical examination can also give you clues whether your patient is high risk or low risk for malignancy. Plus, given your history and physical examination, then you can be able to proceed with the appropriate diagnostic test to request to confirm your diagnosis and to help you decide what is the next step in the approach to a patient with thyroid nodule. So, who are the people who are more prone to develop thyroid nodules? So, your elderly patients are more likely to have thyroid nodules as part of the aging process. Females are also very prone to thyroid nodules. Um, People living in iodine deficient areas or don't use iodine supplementation in their food, they're also prone to thyroid nodules as a compensatory mechanism for the lack of iodine in the diet. And lastly, your radiation exposure also puts patients at risk for developing thyroid nodules. So this part of the history is very important also, and will give you a clue whether the patient is high risk or low risk for malignancy. So, who else? So, what are the things that you should ask in the history that would suggest an increased risk of malignant potential? So, if the patient is either very young or very old, that puts the patient at increased risk of malignancy. Males also are at increased risk. The fast growth of a nodule is also a risk factors for cancer. So patients who have dysphonia or who have voice changes, dysphagia, or even dyspnea, especially when they lie down in bed, that also gives you some clues that this may have some invasion into your nearby structures of the thyroid, such as your larynx and your trachea, and that gives you also a clue that the patient has a possible malignant nodule or thyroid mass. History of head and neck irrigation, very easy to ask in the history, but very important. And of course, patients with a family history of medullary thyroid carcinoma, or patients who have families of multiple endocrine neoplasia or papillary thyroid carcinoma also puts this patient at increased risk of malignant potential. So, what are the things that you have to look out for when you physically examine a patient with a thyroid nodule? So, first you look at the thyroid volume and consistency. So, if the patient has a diffusely enlarged goiter, then that points probably to the possibility of a hyperthyroid disorder, more commonly your Graves' disease. Um, the the consistency of the thyroid nodule, if it's hard and fixed, then probably that also gives you a clue that it may be a malignant tumor. The location of the nodule, its consistency, size, and number of nodules is also very important to take note. The presence of neck tenderness or pain, this can actually be a clue for the presence of thyroiditis. And the presence of cervical adenopathy. I had a patient before. Her presenting symptom was just a cervical lymphadenopathy. And when they biopsied that lymphadenopathy, they found out that it was actually papillary thyroid carcinoma. And when they did a total thyroidectomy, they could not palpate any thyroid nodule. And when they did the total thyroidectomy, um, they found a papillary microcarcinoma in the histopathology. So that's how important it is that you look for this cervical lymphadenopathies as a clue that your patient might have a thyroid malignancy. So, what are the features in the physical examination that may suggest an increased risk of malignant potential? So, nodules that are firm or hard in consistency may be malignant. Those who are fixed and with the presence of cervical lymphadenopathy um, may be clues that the patient may have cancer, and you can actually push the patient to proceed with the succeeding workups. So the next step in your after your history and your physical examination, you now go to your um, diagnostics. And one of the most important things to request is, of course, your thyroid imaging, which is your ultrasound. So there are a lot of studies investigating the sonographic features and the risk of malignancy. So they finally eventually decided to do a systematic review and meta-analysis to combine all the information from all the studies, 41 studies in total, and they were able to quantify the risk of cancer for each clinical and ultrasonographic feature. So, with the clinical features, the things that you find in the history and physical examination, these are the three most important features that will point to a clue that the patient might have an increased risk of thyroid cancer. So, patients with a family history of thyroid cancer are twice more likely to actually have thyroid cancer. And patients with history of head and neck irrigation are 30% um, have a 30% increased risk of malignancy, while patients who are males have 22% increased risk of thyroid cancer. So, what are the tests that we need to request? So, aside from what I mentioned before, the thyroid ultrasonography, you also test for your thyroid hormones and antibodies if necessary. So, your thyroid hormones will help you tell whether this patient is hyperthyroid, hypothyroid, or euthyroid. And of course, your FNA or your fine needle aspiration biopsy or fine needle aspiration cytology will also give you a lot of clues whether your patient might have some form of malignancy. So you use all of these diagnostic tests to help you appraise your patient what would be the next best course in the management of their thyroid nodules. So for the laboratory testing, again from our previous lecture, the most important tests that you will request will be your thyrotropin or your TSH. So if your TSH is normal, then you don't need to do any further testing. If your TSH is decreased or is suppressed, then you can request for your FT4 to determine whether you have an overt hyperthyroidism or and your total T3 or your FT3 to help you detect T3 thyrotoxicosis if your FT4 is normal. If your TSH is increased or your patient is hypothyroid, then you request for your FT4 to determine whether you have subclinical hypothyroidism or overt hypothyroidism. And you can also request a TPO antibody to help you detect whether your patient might have Hashimoto's thyroiditis as a clue as to the cause of the hypothyroidism. So in nodular thyroid disease, the risk of thyroid malignancy increases with serum TSH. So this graph shows the levels of TSH comparing those with papillary thyroid cancer as shown in the gray bars compared with patients with benign nodular thyroid disease as shown by the white bars. And it's obvious from the graph that patients with papillary thyroid carcinoma would have higher TSH levels across all age groups. So your level of TSH will give you a clue as to the risk of thyroid malignancy. So preoperative TSH levels, the higher it is towards the upper limit of normal, may point to a malignant disease, and those who are on the lower end of the normal values would point to a non-malignant disorder. But of course, this is not a hard and fast rule. These are just clues as to the risk of thyroid cancer in a patient with thyroid nodule. One of the most important tests to do is an ultrasound evaluation. And the ultrasound evaluation is recommended for patients who are at the risk for thyroid malignancy, have a palpable thyroid nodules or goiter, or those who have neck lymphadenopathy suggestive of a malignant lesion. So the ultrasound features that are associated with an increased risk of thyroid cancer are listed here. So just by ultrasound alone, you can actually gauge whether your patient is at an increased risk of thyroid cancer. Oh, if the patient has all these features, then you can actually already prime your patient that based on the ultrasound features, there is a big chance or a small chance that you might have thyroid cancer. And that's what we want to find out. So if in the study, in the meta-analysis I presented a few slides ago, they found that the ultrasonographic feature of having taller than wide or a nodule height greater than the width would be the highest risk for thyroid malignancy. So, taller than wide. Okay? So, if a patient with a taller than wide nodule, this regardless of its echogenicity, regardless whether it's hypoechoic, hyperechoic, or isoechoic, you have 10 times increased risk of thyroid cancer. Next is your absent halo sign. So this nodule is very ill defined. There's no obvious border or a halo sign. And in this nodule, you have some halo here, but it is incomplete. Okay? It's incomplete in this part of the nodule. So this feature puts the patient at 7 times increased risk of thyroid cancer. So the other features such as microcalcification, irregular borders, hypoechogenicity, solid nodules, and intranodular vascularity are some of the other ultrasonographic features that are associated with thyroid cancer. So when you evaluate patients with thyroid nodules, it's very important to look at the thyroid as a whole and not look at the individual nodules per se. So just like the 7 blind man evaluating this elephant, if you just look at one portion, you'll be only able to see that portion, But when you look at the totality, then you'll be able to see the whole elephant and you'll be able to identify what is the problem of your patient. So therefore, they lump up all the thyroid features and they were able to summarize everything into the American Thyroid Association guidelines. And they've already summarized the different features that you look for in the ultrasound. So if you have these features, okay, then the suspicion of malignancy is high. So if you have patients with nodules that have microcalcifications, or you have a hypoechoic lesion compared to the thyroid parenchyma with irregular borders, you have a hypoechoic nodule that is taller than wide, you have nodules with irregular margins, you have interrupted rim microcalcification with soft tissue exclusion. This probably represents local capsular invasion, and nodule with irregular margins. These are all ultrasonographic features that are highly suspicious for malignancy. So if you have already ultrasound feature like this, then you can really push the patient to undergo the next step, which is your fine needle aspiration cytology. So with all these features, you can actually, they already summarized everything. Based on the ultrasound, you can actually tell the patient or your ultrasonography, your nodule based on the ultrasound is have are very um low risk for malignancy. Therefore, we can opt to wait and observe, or we can opt not to biopsy for now and see for later. Or there's absolutely, for example, you only have a thyroid cyst and the risk of malignancy is less than 1% regardless of size, then you don't need to advise the patient to proceed with your fine needle aspiration biopsy because the risk is very, very low. So if you have a patient with a suspected thyroid nodules with a normal TSH or elevated, then you do a thyroid neck ultrasound. If you have suspected thyroid nodule with a suppressed TSH, the risk of malignancy is very low, so you might opt to observe and treat the hyperthyroidism or subclinical hyperthyroidism if indicated. Then you are warranted, you are not required to do a thyroid ultrasound at that point. But if it's normal or elevated, then you proceed with neck ultrasonography. And based on the features in the neck ultrasound, then you'll be able to classify the risk of malignancy based on the appearance. And if if the nodule has a high suspicion or intermediate suspicion pattern, then you look at the size of the nodule. If it's more than or equal to 1 centimeter, then you're warranted to do an FNA. If it's smaller than 1 cm, it will be very difficult for the for the um, for the person doing the biopsy to accurately do the biopsy. So it's not really recommended to do a biopsy less than 1 cm. If the features on the ultrasound is only low suspicion or very low suspicion, then the cutoffs for the size of the nodule will differ. So if it's low suspicion, you only biopsy if it's more than 1.5%. If it's very low suspicion, then you only do an FNA if it's already more than 2 centimeters. If it's a very benign pattern, a simple thyroid cyst, no FNA required regardless of size. So any nodule more than 2 cm, you're already warranted to do an FNA cytology. So based on the FNA cytology, you will now be able to categorize your nodule based on the Bethesda system. And your Bethesda system will classify your nodule either non-diagnostic or unsatisfactory. So not enough cells was picked up by the fine needle aspiration. So you can opt to repeat the FNA, especially if you're highly suspecting a thyroid cancer. If it's benign, then you can prime your patient. The risk of malignancy is only 0 to 3%, so we can opt not to do any further surgery. Now, this two classification, your ATP of undetermined significance or AUS, or your follicular lesion of undetermined significance, and your follicular neoplasm or suspicious for a follicular neoplasm are now the gray area. And these are the risk of malignancy. But if you have patient with Bethesda classification, suspicious for malignancy, then your risk for malignancy goes up to about 60 to 75%. And your fine needle aspiration biopsy can also tell whether your nodule is malignant or not. And if it turns out to be malignant in a fine needle aspiration biopsy, then you are almost most certain that this is a thyroid cancer, because the risk of malignancy goes high as 97 to 99%. So you're almost sure it's cancer. So based on the cytology, these are the recommendation. If it's non-diagnostic, you repeat. If it's benign, then you just observe. If it's in the gray area, AUS, FLUS, or follicular neoplasm, or suspicious, then there's a corresponding recommendation for this. If it's malignant, then you go straight to surgery. So if it's the ATP of undetermined significance, you can repeat the FNA or do molecular testing if it's available in your setting. So in the Philippines, molecular testing is not available. If you really want to do it, the patient can afford it, you can actually send it to Singapore for molecular testing. Or you can opt to do surveillance or diagnostic surgical excision. But in patients like this, it's also very important to look back at the history, PE, and the sonographic features. So if the patient, based on the history and physical examination, are high risk, for example, the patient is male, has history of neck irrigation, or as a family member with thyroid cancer, then maybe even if it's just an AUS, you can proceed to advise thyroidectomy. Or the sonographic feature shows like microcalcification, irregular borders, those in the high risk of malignancy based on the sonographic pattern, then you can push the patient to do the thyroidectomy. Or if the patient prefers to just do the thyroid surgery anyway so that he doesn't have to worry about whether his nodule is malignant or not. So there are patients like that also. There are patients, on the other hand, who don't want their thyroid nodules removed if it's not sure whether it's malignant or not. So it's really up to how you talk with your patient. You share the decision with them. You give them all the information, and it's really up to them whether they want to proceed with surgery or not. So it's a shared decision-making process. So this illustration shows you the spectrum of the different classifications of your thyroid cancer. So your benign nodules will be very low risk for malignancy, and those who are malignant will be very high risk for malignancy. And based on the risk of malignancy, you can now have an idea whether to be conservative or whether to lean towards surgery. So if it's a benign nodule, you can just simply follow up the patient. If it's an AUS, you can opt to repeat, or you can look back, consider ultrasonographic and clinical data to determine risk of malignancy. But if your patient is in the intermediate category, it's a follicular neoplasm, then you can suggest surgery or just care for follow-up depending on your discussion with your patient. Or if the patient is high risk, you can suggest surgery with intraoperative pathology, or if it's malignant, then you can straight away suggest total thyroidectomy and refer the patient to surgery. But in the Philippines, patients with um, suspicious or suspicious on the FNA cytology, we recommend total thyroidectomy right away, because we found that in our population, our thyroid cancers are very aggressive. We want to minimize second look surgery. Second look surgery is when you do a lobectomy and then you find out it's positive, then you go back to the patient and do the other thyroid lobe. We want to avoid that, because the second surgery would be more difficult technically, and it puts the patient at higher risk for surgical complications such as your post-surgical hypoparathyroidism, bleeding, etc. etc. Okay, so the American Thyroid Association actually devised a risk stratification system to help you decide about the intensity of treatment post-operative. So for example, the patient decides to undergo total thyroidectomy. After total thyroidectomy, you can classify the patient whether it's low risk, intermediate risk, or high risk based on the histopathology. So if you have a patient with a histopathology report, then you can look for these features and be able to tell that the patient is low risk. So for example, the patient is classified to have papillary thyroid cancer with no local or distant metastasis. So or all macroscopic tumor has been resected by the surgeon. There's no presence of tumor invasion of locoregional tissues or structures based on the microscopic evaluation. The tumor doesn't have aggressive histology such as your tall cell, hobnail variant, your columnar cell carcinoma. If the patient has already undergone radioactive iodine therapy and there's no metastatic foci outside the thyroid bed, all these features, no vascular invasion, all these are considered low risk. Okay. Other low risk patients are those with intrathyroidal encapsulated follicular variant of papillary thyroid carcinoma, low risk for invasion or metastatic spread, intrathyroidal well-differentiated follicular thyroid carcinoma without capsular invasion or minimal vascular invasion, intrathyroidal papillary microcarcinoma or papillary thyroid carcinoma that is less than 1 cm, that's considered microcarcinoma. So all these are also considered low risk. Patients who have these features on their histopathology report, such as or intraoperatively observed by the surgeon, such as macroscopic invasion of tumor into the perithyroidal soft tissues, incomplete tumor resection, distant metastasis, post-operative serum thyroglobulin that's very high, suggestive of distant metastasis, presence of lymph node invasion, as well as follicular thyroid cancer with extensive vascular invasion. All these features classifies your patient as high risk. So everything in between will be considered intermediate risk. And the intensity of treatment will depend on the initial risk stratification. So if the patient has low risk, then the intensity of treatment will be less intensive. If it's high risk, then the intensity of treatment, the frequency of monitoring will be more intensive. So the initial therapy is of course total thyroidectomy with or without neck dissection depending on the intraoperative findings of the of the surgeon. And after thyroidectomy, you evaluate post-operative disease status. So you do a thyroglobulin test. If the thyroglobulin is um, very low, 0, 1, or 2, then most likely the surgeon was able to take out most of the tumor. And then you can do either a diagnostic scan or you can proceed with radioactive iodine remnant ablation. So what we do here is after thyroidectomy, you let the swelling subside, and then you refer the patient for radioactive iodine therapy. You ask the patient to swallow a capsule with radioactive iodine. The patient stays in the hospital for maybe 2 days, and then the patient is sent home to be isolated for several days, and then the patient undergoes a radioactive iodine 131 whole body scan to determine whether the iodine that they took for remnant ablation will be found elsewhere in the body. So you'll be able to tell whether the disease is localized in the thyroid bed or they're spread elsewhere in the body, such as in the bones or in the lungs. If the if the patient is low risk, this can be optional. If the patient is intermediate, then you can consider. If the patient is high risk, then we highly recommend remnant ablation. And then after RAI remnant ablation, then you need to proceed with TSH suppression, because if you have elevated TSH, that would stimulate your thyroid cells, if there are any remaining, to grow again. So if the patient is low risk, the intensity of TSH suppression will be just 0.5 to 2. If the patient is high risk, then you have to really suppress your TSH to less than zero point 0.01. And how do you suppress your TSH? You give the patient levothyroxine. So the goal of giving levothyroxine post-operatively is not just to replace thyroid hormone or make your patient euthyroid, but also suppress the TSH to prevent recurrence or to decrease the risk of thyroid cancer recurrence. So how do we evaluate response to therapy? We monitor thyroglobulin maybe about every 6 to 12 months. We can also do neck ultrasound to determine any structural recurrence. And then if the patient is intermediate and high risk based on the ATA risk stratification, you can do a diagnostic full body scan. Or if you have history, you suspect, let's say, cervical lymphadenopathies or presence of um, lung metastases or metastasis elsewhere, then you can consider CT, MRI, or even FDG or FDG PET scanning. And then after you do all this tests, then you can classify the response to therapy. So if the patient has undetectable thyroglobulin, nothing found on the ultrasound, nothing found on the diagnostic whole body scan, then you can say that the patient has an excellent response. If the patient has an elevated thyroglobulin but elsewhere there's nothing, there's no structural disease, then you can classify as a biochemical incomplete response. If the thyroglobulin testing is not detectable, but there's something in the neck ultrasound and in the diagnostic whole body scan, then you can say it's structurally incomplete response to therapy. Or it's hard to tell, so you can classify as indeterminate. So here are the different definitions. Okay, so you don't have to memorize this, you just need to be familiar with it. I don't expect you to memorize up to this level, but just so you know that you need your thyroglobulin post-operatively, as well as your neck ultrasound and even your diagnostic body scan in certain patients to be able to classify whether you have good response, excellent response, or incomplete response to therapy. So now we go to the summary. So the take-home message for this lecture is that thyroid nodules are prevalent conditions where the priority in the workup is to exclude the possibility of malignancy, and a stepwise approach is needed, and it involves a detailed focused history and physical examination as well as biochemical testing with TSH, imaging with ultrasound, and of course your fine needle aspiration cytology are all essential for proper diagnosis. And the management of differentiated thyroid cancer, which includes your papillary and your follicular thyroid cancer, must be individualized depending on the risk assessment and must be regularly reassessed for subsequent courses of action. So that's it. I hope you learn something in today's flip class. So we'll talk about, we'll discuss more of the cases after the quiz on our next session on Wednesday. So I hope you learned something today. So make sure you click the link below, and if you want to see the original lecture. The reference for this lecture is your ATA guidelines for thyroid cancer and, of course, your Harrison's. Good night.